Of cyanide poisoning are, in the pulmonary system, dyspnea, because what's happening is the cyanide is affecting the cytochrome oxidase system, your cell's metabolic system, which allows it to use oxygen appropriately. So it shuts that down. So the patient becomes dyspneic. They become air hunger. Tachypnic, air hunger again, and then ultimately apnea. The central nervous system shuts down. CNS symptoms, in order of magnitude, headache, so it's like carbon monoxide, and that's it. Headache, drowsiness, seizure, and coma. So in a closed space house fire, if the patient was reported to have been unconscious and had a seizure, you don't know whether it's carbon monoxide poisoning or cyanide. Now, cyanide is, I'll interject at this point. According to the burn center folk in Portland, cyanide poisoning in house fires is grossly overrated. Now, cardiovascular symptoms of cyanide poisoning is tachycardia, goes along with the tachypnea, hypertension to start with, then hypotension as the metabolic systems begin to fail, then bradycardia, cardiovascular collapse, and asystole. So we use in our protocol for ingestion or inhalation if you have signs of poisoning or if you have evidence of poisoning, like the person is found collapsed in a silicon wafer workshop, and there's a leak in their gas system, and they're down, and a couple of other people are down. You can say, well, this is probably cyanide poisoning. It's the gas leaking in there, and I think you take, personal protection going in there. Then signs of poisoning would be altered mental status, seizure, coma, tachypnea, apnea, shock, vomiting. And you're going to hyperventilate the patient with 100% oxygen. Assist ventilations. If they're breathing on their own and able to tolerate it, a CPAP would also help. You begin to suspect cyanide poisoning when normal treatment doesn't seem to be getting you anywhere. So if the person is still comatose, despite 100% O2, what appears to be a normal SpO2 on your pulse oximeter, you've got to think something else is that. If the patient wakes up and starts doing better with your treatment, I can guarantee you that is not a significant cyanide poisoning, because you don't wake up from the significant cyanide poisoning. The antidote that we're using is the simple old-fashioned one. It's cheap, and it doesn't confuse the thing. The problem with using the cyana kit is that according to the director of the poison control, or the burn center, once you use the cyana, remember the admonition: don't determine the CO level before you give them the cyana kit. If you give them the cyana kit, your SpO2 and CO monitoring ability is maybe lost for up to 4 weeks, because it's a colorimetric thing, and the cyana kit changes your hemoglobin colorimetrics. So you probably can't do so they'd have to do a blood gas, an arterial blood gas, to see what the oxygen level is all the time. Sodium thiosulfate, the cheap thing, the easy one, doesn't do that. We use 50 cc's of a 25% solution infused over 10 to 20 minutes. and that produces a soluble salt which is removed by the kidney. That produces sodium thiocyanate, which is not toxic. And it's cheap. This is real cheap. The cyana kit now is pushing $1,000 just for one person treatment. We're going to leave it for the ERs to determine that if they really need to do that. And it outdates about every year. So you have to redo it and redo it and redo it. So it becomes too expensive. Calcium channel blocker, beta blocker overdoses. Well, excessive beta blocking gives you nausea, vomiting, headache, dizziness, confusion, profound hypotension, cardiac dysrhythms, and bradycardia. Bronchospasm, they increase one of the risks of giving a patient who needs, one of the risks of treating for hypertension. A lot of times we use beta blockers, and particularly beta blockers were in vogue at one point for hypertension. If you have asthma, you can increase the frequency of attacks. I have had a couple of patients, including my aunt, who used a beta blocker drops for glaucoma, and that triggered asthma attacks. So she had to go to something else, use the old-fashioned kind of treatment. Patients with pulmonary edema, because beta blockers and calcium channel decrease the inotropic of the heart, and so it increases the risk of congestive heart failure. So, signs and symptoms of calcium channel or beta blocker overdoses. You should know what they are because they have the pills at home. If they have hypotension and bradycardia, treat bradycardia first with atropine. Treat. If they had a calcium channel overdose, give calcium chloride. We don't carry calcium gluconate. It's 4 times as expensive, and you have to use more, so the calcium chloride works fine. It's not enough to cause a chloride overdose. If they had a beta blocker, if you know it's a beta blocker overdose, you don't have to give them the calcium. Duh. Glucagon. Now, this is if the patient is still bradycardic despite your atropine. Try some glucagon, and the dose of glucagon is expensive. It's 5 milligrams IV for the adult, and a child gets 0.1 milligram per kilo. Glucagon is now gone to, John sent me a thing just the other day, it's gone to almost $200 for a 2 milligram unit. Fluid challenge. Any hypotensive patient gets a fluid challenge unless they're in congestive failure or have signs of pulmonary edema. Pace as needed. Epinephrine and or dopamine by drip to increase heart rate as well as to treat hypotension. Now, we see a lot of this. Hyperadrenergic syndrome. Cocaine, methamphetamines, MDMA, ecstasy present with hyper, tachycardia and arrhythmias, agitation, diaphoresis, mydriasis, hypertension, hyperthermia. The opposite, mydriasis, the opposite pupils of a narcotic overdose. Now, what if you took a narcotic as well as, well, then you'd probably have a mid-range pupil. A balanced diet. Yeah. Okay, treatment of hyperadrenergic induced arrhythmias. They also will have seizures sometimes and strokes. 100% O2 Versed. If they have stable VTAC, I would prefer amiodarone, although lidocaine is probably just as good a choice. If they go into VFib from their hyperadrenergic state, treat a VFib just like you treat any other VFib, except decrease the hyperadrenergic epinephrine that you're going to be giving them to about a milligram every 5 minutes instead of every 3 to 5 minutes. Opioids, yes.
Had a couple calls downtown, predominantly at the library, but teenagers down in the bathroom, just like that, but they've been smoking spice.
It's coming up. Coming up. Coming up. Hang on there.
Question?
Yeah. Yeah. Okay, opioids. Okay, so heroin, morphine, fentanyl, China white, tar heroin, brown heroin, what have you. Signs and symptoms of opioid overdose: CNS depression, respiratory depression, and meiosis, pinpoint pupils. Now, not all narcotics, some of the narcotics don't end up with extreme meiosis, mid-range pupil, but those aren't very popular anymore. That's not what we see. When you're seeing pinpoint pupils, it's mostly always a heroin or a heroin congener around here. Now, treatment of opioid toxidrome is pretty straightforward. Oxygen, intubation is needed, but not in that order. What we do is, you do an altered level of consciousness protocol. Glucoscan. If they're low on sugar, give them sugar. Narcan dosing regimen is pretty straightforward. Don't forget you have IN availability now, so you don't have to start an IV. You don't have to have an IO. You can give the Narcan nasally. What do we treat Narcan? We treat respiratory depression with Narcan. If you have someone who's just having a good high, you don't have to wake them up. You can if you really don't like them. And this kind of person you want to titrate your Narcan to. If you're treating respiratory depression, that's where you give the adult the full 2 milligrams of Narcan, and maybe even repeat it. And IN works just as well as IM, works not quite as well as IV if you have a good central line, but pretty close. IN is a straight shot to the opioid receptors in the brain. So, if they just have altered mentation, I don't want you going over 0.5 and just keep titrating up to desired thing. You don't have to withdraw them and have them all anxious. Now, withdrawal is uncomfortable. It is not generally severe in the sense that heroin, opioids, as a rule, do not have seizures as part of the withdrawal phenomenon. They wish they had seizures, but they don't. The only one that has seizures, well, 2 cases that you have to be very cautious on. A baby who might be, who is maybe an addict because his mother is an addict, and so the baby is now also an addict. Because their brains are not well insulated yet, they will have a seizure if you withdraw that baby with Narcan. So you titrate to an infant also, a newborn. Also, a person who's an addict and who is on methadone. Methadones do have seizures on withdrawal sometimes. All right, synthetic marijuana. I love the names of these things, including spice. Purple Haze, Mr. Happy, Climax is good, Tsunami, Crazy Kush. Ugh. So, also called incense, potpourri, plant food, clever. They were developed to legitimatize THC, never tested on humans. Most of these come from overseas sources. Use alcohol or acetate to dilute it, spray it on herbal leaves, and then you smoke it. They bind to the cannabinoid receptors in the brain. I mean, how did we evolve with cannabinoid receptors in our brains? Good question. So it's the same receptor sites as THC, but they bind stronger. It also may affect the NMDA receptor in the brain. So you end up with similar effects as PCP, ketamine, and methadone. So they can become very odd. Their desired effects, of course, of smoking dope is calmness, alleviation of nausea, but what they actually get is more anxious, agitation, intense hallucinations, paranoid delusions, psychosis, suicidal ideations, etc., accompanying with vomiting, tachycardia, hypertension, chest pain, dyspnea, tremors, seizures. In other words, another hyperadrenergic syndrome.
We need to legalize that.
Yeah. So supportive treatment, symptom-based, chemical restraint. These may go to excited delirium or close to it. And excited delirium, your treatment is Versed, 5 to 10 milligrams. I'd go to 10 for a normal size adult. 10 milligrams IM, because you're not going to be able to start an IV on them. Followed by full dosing of anapsine or Haldol, or if you don't have anapsine or Haldol, Geodon. Well, we have one of all three. Yeah, you've got Geodon. The Fire has Geodon now. Anapsine is still back ordered. Haldol is on. We've got Haldol. So. Oh, it's been in the protocol for what?
It's been out.
Yeah.
Coming back.
Yeah.
New iteration will come out.
I don't like it. I don't like it as well as anapsine personally, but that's another story. Whenever I get my agitated delirium, give me. Okay. Now, synthetic canthinones, bath salts. You know that these are funny things when one of the brand names is Charlie Sheen. Once again, these have similar effects as methamphetamine and cocaine, so they're sympathomimetic again, they're hyperadrenergic. Canthanone is a naturally occurring active ingredient. They eat it, they chew it and smoke it in, I think the khat plant comes from Cambodia and India, that part of the continent of Asia, and South Africa. And I believe that some animals enjoy eating this stuff. Onset of these things, now the bath salts are 30 to 90 minutes. Half-life is about an hour and a half. Increased dopamine and serotonin neurotransmitters in the brain. So it's once again it's like PCP effects, and they get very agitated. Superhuman effect, severe aggressive behavior, paranoid delusions, acute psychotic, homicidal ideation and attempts, suicide ideation and attempts, and then long-term they get persistent mood changes. It really does mess you up. Physiologically, They have nosebleeds, nausea, vomiting, hypertension, tachycardia, palpitations, chest pain. In other words, another hyperadrenergic syndrome. Treat them. Supportive, symptomatic base, use your hyperadrenergic protocol, use high doses of Versed, whatever our neural quieting drug is, whether it's Haldol, Enapsine, or Geodon, and restraint. This is where the police will probably ask you to assist them, and you may ask them to assist. And these people are pretty touchy. Last thing, we see out there a lot of caffeine-related things because it's cheap, it's easy to get, and it's totally legal. The center bar is what you get with 1 cup of coffee. The top ones are 5-hour energy, extra strength, rock star energy shot, etc. Clearly, even Starbucks isn't there up there very high on the list. But that's a lot of caffeine. So teenagers, young adults, skiers, etc. People want to stay up at night, partying, mixing with alcohol, other things. Once again, adrenergic symptoms, insomnia, irritability, nausea, tachycardia, hypertension. They can have SVT commonly, can have seizures, altered kidney function, rhabdomyolysis, supportive treatment, do your normal LOC protocol, treat dysrhythmias as you see them, treat SVT and tachycardia as you see it, and anticonvulsants as needed. Yeah.
I have one suspected caffeine powder incident in the field. Have you noticed any of those or heard of any of those in the
Marty? No.
I didn't know if there was a treatment already up there or not.
How did they allegedly take this? Just eat it?
Powdered and stirred into a drink.
Oh. Yeah. Just mentioning, the last thing I'm going to mention is the SUD study. Sudden unexpected death study. We're doing a genetic evaluation of what may put people at risk for heart attacks, and this could include any patient with a pre-hospital cardiac arrest, even if they have an ROSC, and what we do is have AMR draw blood as soon as feasible after the IVIO start, and it's labeled, turned in along with the hospital face sheet if you got one, put in the ambulance cooler, and then it's taken care of by the supervisor. So, exactly an hour.
Good work.
Yeah. All right. Let's take a break for 10 minutes, and then Dr. Bell will go on with his portion.
Just a refresher, this is a tool that we use every day in the pre-hospital arena and also in the hospital. It's a very powerful tool, and it's one that we can always kind of refresh our knowledge and learn new little things, and I hope to add to your knowledge base a little bit today in this talk. So 12-lead electrocardiography. Kind of a basic review of the electrical conduction through the heart. And obviously the basic anatomy is that you have 2 small chambers and 2 large chambers, and there's special conduction tissue that is present in the heart. The sinoatrial node and the AV node are the pacemakers, and the SA node and the AV node are connected by interatrial pathways. And beyond the AV node is the bundle of His, and then it breaks up into the left bundle and the right bundle. And this is the way electricity is normally conducted through the heart. Now, there are pathologic changes that occur both congenitally and over time because of injury or insult of some kind that may alter this progression. But this is the standard display of normal conduction through the heart. So you have a P wave, which is the depolarization of both the right and the left atria. And you don't see the repolarization phase because the QRS complex actually overrides that. So you don't see the depolarization phase. You do see depolarization of the ventricles that we'll talk about as we go on. So QRS, the big complex, is the right and left ventricular depolarization. ST and T wave represent ventricular repolarization. So you have depolarization, then repolarization to get back to the initial state. A U wave is very uncommonly seen, but can represent after depolarization, and may be present in severe hypokalemia, I believe. I don't know if I've ever actually seen one, but it is described. PR interval is the onset of the P to the onset of the QRS, PR interval. So that's important when you're thinking about rhythm disturbances and bradycardias and looking for PR prolongation and the relationships of the P waves to the QRSs in terms of blocks. QT interval, this is very important and has a significant impact on potential for malignant dysrhythmias, especially ventricular dysrhythmias. So it's the duration of ventricular depolarization and repolarization combined. RR interval is the duration of the ventricular cardiac cycle, and RR interval is an important thing to look at, and it's not only for just the rate effects, but also with the regularity to see if there could be potential arrhythmia. PP interval is the duration of the atrial cycle. Standard limb leads, this is kind of a review for everyone. You have both the standard limb leads and the precordial leads that we use to depict the conduction of electricity through the heart. Each small box on the electrocardiogram represents 0.04. Every 5 boxes of those small boxes is 0.2. And 5 of those 0.2 gives you a second, 1 second. So there's how many little boxes in a second? So it'd be 5 times 5, I guess, right? 25? And 75 in 3 seconds. So if they have a 3-second pause, that's 75 little boxes. So this is basically just each lead is a view of the heart and how that particular lead is seeing the electrical conduction through the heart. So each one is going to be unique because of the view it gets, and it can often be the case that something may be completely invisible to certain of those leads, and you may pick up an abnormality in maybe only 1 or 2 leads that may be significant for the patient's diagnosis and treatment. Now, the way this is drawn here is a little bit confusing. This is the way the leads are put on, but if you look at this, and it's been depicted in, I can draw this up on the board. Which would be easier here. If you take this as lead 1, this is F, this is 2, this is 3, and this is L. And what we have is R over here. So this is a big asterisk. But it gives you more of a sense of what contiguous leads are, okay? And so what you see here is leads 1 and L. They give you a view of the lateral wall of the heart. And over here, you can see the inferior leads, 2, 3, and F. It gives you a little bit better depiction of what contiguous leads are. Now, the precordial leads are pretty straightforward because they're all across the precordium. And R, I'm going to mention at the end of the talk about its potential significance. Precordial leads, these are standardly put in the 4th and 5th intercostal spaces. And you know about the placement, and you know about right-sided leads. In the case of an inferior wall, am I to determine whether this may have, you know, if they have an ST elevation MI, inferior wall. You want to know whether this is extending onto the right ventricle. That has significance in terms of your therapeutic approach. You want to be very careful about giving nitrates or beta blockers or even narcotics to those patients because they may be very volume dependent and you may drop their pressure. So this is the evolution. And this way electrocardiography are really useful tools because they can be used initially to make a quick diagnosis, but they can be used over time too. Over time, just like we use ultrasound, it's a non-invasive thing that we can use over time and repeat because these changes occur in an evolutionary pattern. And you can see here, this is the way that's depicted from the normal state to the recovery state. So initially, you may get really broad, tall T waves with some really straight uprising of the T wave that are called hyperacute T waves. And these are distinguished from peak T waves you may have heard with hyperkalemia. Okay, so they're kind of tall and narrow. These are wide and tall, so hyperacute T waves. Then you see the ST elevation, and this is something that you're all used to, and look for those changes in identifying acute ST elevation MI. And then you get a phase of Q wave formation where you get some death or infarction of the tissue, and you see Q waves depicted in D there, along with some T wave inversion. And then it progresses again to where you have a fully infarcted area where you have a big